Greetings all that have joined in our PEM lecture series. So in the next 2 minutes, we'll begin our presentation. We're just letting people to finally join in, then we'll start our presentation. So welcome all. Just bear with us in the next 2 minutes. I will let the presenters know so that they can start presenting, because I know there are some that might be joining in right now. Okay, good afternoon, everyone. Welcome to our PEM lecture series, lecture 4. We're very happy to have you all, the participants, once again, and I'm sure majority of you have been following us. This is our lecture series number 4, where we're going to have an exciting topic that is going to be about pediatric radiology in emergency setting. So for those that is the first time joining in, you're warmly welcome, and we always have this PEM lecture series every month, where we always make the announcements both in our social medias, but we also make sure that we post them in every group that we have emergency healthcare workers. So you're warmly welcome, and we're going to start our today's presentation. And we have two specialists that are going to be presenting at this topic. We have Dr. Susan Taylor, who she's from Emory. She's going to present to us today. And we have Dr. Masuma, who is an honorary lecturer at Muhimbili, but also an EM attending at Muhimbili National Hospital. But once they start presenting, they will definitely introduce themselves. So without taking much time, just some few highlights. Right now, you cannot unmute yourself. If you have any questions, just please type it on the chat. I'm going to be checking on the chat so that at the end, the presenters will answer the questions. But as well, if you want to speak at the end, you can just raise your hand and I'll unmute you so that you can speak out and give a question. So as to maintain silence and we have good presentation, right now everybody will be on unmute mode. So I'd like to welcome the presenters to begin the presentation.
Thank you so much.
Thank you for the introductions, Humphrey. Hi, everyone.
Hey, I'm Susan Taylor. I'm one of the radiologists over at Emory. All right. So, well, the way we'll start our PowerPoint is Dr. Masuma will review general concepts of pediatric imaging, and then I'll take the other 2 bullet points of going over some normal radiographic images, and then we'll help identify key urgent and emergent findings on pediatric imaging.
Thanks, Dr. Susan. So by names, as introduced by Humphrey, I'm Dr. Masuma. I work at National Hospital Muhimbili at Mloganzila campus, and I'm happy to be here with you and take you through this session today. So without wasting any time, the first important thing to know is children are not small adults. And therefore, it's always important to understand and reflect on the key differences between pediatric and adult radiology. So what makes them very special? One thing about children is that they are sensitive to ionizing radiation. And therefore, it's very important for us to be selecting the type of imaging that we need based on this factor. They also have immature tissues which are sensitive to radiation, and also because of their smaller body size, their reproductive organs tend to be more closer to the radiation zones. And this makes it relevant when we try to prevent them from exposure. Again, it's very important to take a note on the radiation safety and therefore decrease the number of times we want to expose these children on x-rays. For instance, when we look at one example in our setting, we may have a child being referred from one center to another, and the previous center maybe did an x-ray, and this x-ray was left behind. So by the time they get to a new or the referred center, they need to take another one. So this makes it unsafe. So we always have to refer to what they call the ALARA, as low as reasonable achievable, and therefore minimize ionizing radiation exposure to children. Next slide, please. All right, the other important thing to look on is when do we decide to choose what imaging modality? And therefore, today we're going to talk about one of the 3 among the several other modalities that are there. So to begin with, we do have the ultrasound, and this has different indications. For instance, you will need to do an ultrasound, and especially in the emergency department, there's something called the point of care ultrasound. We do it in cases of trauma, where we do the focused assessment sonography in trauma, or the extended focused assessment sonography in trauma. We do have a point of care ultrasound for patients who come in with shock and hypotension, and we refer to this as the RUSH protocol. We do have a point of care ultrasound for patients who come in with difficulty in breathing. For instance, those who are suspecting to have pneumonia and pneumothorax, pleural effusion, etc. And you can do a point of care ultrasound for patients who come in with intussusception, patients who come in with pyloric stenosis. All of these are some of the differentials that children would present with. You can also apply a musculoskeletal ultrasound for patients who you suspect to have a fracture, or those who come in with an abscess, cellulitis, or other soft tissue disorders. So you may want to ask yourself, what is the advantage of ultrasound? The benefit of this image modality is that it has no ionizing radiation, therefore is a safer option for children, as well as you can repeat it. So it adds the value of repetition. When you compare it to other imaging modality, it is less expensive and also easily available. However, it's operator dependent, and therefore, if the operator does not know how to generate those images in a high quality, then they may end up interpreting something that is not correct. Next slide, please. Okay, when we come to x-rays, you do know we do have different indications for selecting x-rays. You could decide to do a chest x-ray, abdominal x-ray, extremity x-ray, and so on. But we will go through the indications of each of these x-ray modalities and see at the end of the day the advantages and disadvantages, just as highlight. When we come to a chest x-ray, you would want to order this if you are thinking or want to evaluate respiratory or cardiac condition, and children would come in with different forms of difficulty in breathing, either from a pneumonia or congenital heart disease. So it's important for you to go through this. A patient you're suspecting a pneumonia and want to look at this, there is utility of using a point of care ultrasound. However, you could decide to order an X-ray as well. Patients coming in with a pneumothorax, patients who come in with, say, foreign body aspiration. We do know that children can sometimes aspirate different forms of things, from radiopaque to radiolucent substances. Patients who come in with foreign body ingestion, those who come in from different causes of trauma. And as well, you know that in the ED, you can do multiple procedures that, for instance, placing a chest tube or putting an central line, and therefore you would want to do a chest X-ray if you are wanting to check the position of those lines and tubes. When we come to abdominal X-rays, in cases such as intestinal obstruction, or you are thinking of bowel perforation, or it's an ingested, again, foreign body, such as different forms we're going to see later on, and as well as looking into nephrolithiasis. These are stones in the urinary tract system, and there are stones that are radiopaque that can be visualized on X-rays. And you again would know extremity fractures for patients who come in with trauma from different sources, getting fractures in the limbs. You would want to order an X-ray. So the advantages of this image modality is that comparing to MRI and a CT, it is less expensive and it's usually readily available. Most centers have this. However, with frequent exposures to ionizing radiation to children, it places a potential risk to these children, as previously explained. And it's also not a good imaging for soft tissue or other organs, other organs and muscles. All right, next slide, please. And then the last imaging modality that I'll speak of today is CT scan. Pardon the background noise. I'll talk about the CT scan, and we have different indications for doing a CT scan. You can have a patient who has trauma to the head and you want to order a CT. However, there is a rule that I'll ask you all to go read about, the PEM rule, to decide. That is a clinical decision rule that will help you decide which patient would need an imaging. We do have different reasons why we would want to order spine CT, again, in patients who are having trauma, and also when the X-rays are not sufficient to give us a clue about the C-spine. You would order a chest CT for various complications around the chest, such as congenital anomalies from different causes. Maybe they did it's a post-operative complication, let's say from a cardiac heart surgery, patients with different infection in the lungs, and chest X-ray wasn't suggestive, so you may want to order a chest CT. Again, you may have abdominal CT ordered depending on the scenario of your child, coming in maybe with symptoms related to an appendicitis, or you're thinking of certain birth defects. And then you can order also a pelvis CT. For instance, you're thinking again of urolithiasis. So the advantage of this modality is that it's high quality. It gives you 3D images. However, the radiation exposure is again a higher, it's much more compared to an X-ray. Again, there is risk of posing to allergic reactions from contrast agent, especially when you're ordering a contrasted CT. And again, children would definitely need procedural sedation when taking CT because of how the whole process, putting a child into a CT scanner is sometimes scary. So at the end of the day, they need to be sedated so that to minimize those movements. And then you do have limitation in that you may not be able to visualize soft tissues compared to other imaging techniques, such as a magnetic resonance imaging. All right, now, after this, I'd like to now invite Dr. Susan, and she will take us through the images, how to view the normal images, and then see the pathological ones. Dr. Susan, the mic is yours.
Thank you, Dr. Masuma. All right, so we'll start with some normal radiographs of things. We'll start with the chest. So when you're learning how to read chest X-rays, I think the most important part is to follow a system, so that way you don't forget to look at any particular organs. But in the interest of time, I'm going to do a very quick one that I kind of look at. So I'll start centrally. Here's the trachea. Here's as it divides into the main stem bronchi, and here's the carina. And then I'll kind of look out at the lungs kind of globally to see if there's anything that I catch just looking at the x-ray. And then I'll go side to side at the same level to see if there are any opacities as you kind of go back and forth that are asymmetric to one side versus the other. You'll want to look at your costophrenic angles, make sure that they're nice and sharp. And then coming back centrally, here's the cardiac silhouette. So this is the right heart border and the left heart border. This is the pulmonary outflow tract, and the aorta is sort of up in this area. There's not a good aortic knob as much on this picture, but making sure that all those contours look normal, the heart size looks normal. And then after that, it's kind of looking at the bones and soft tissue. So here are some of the ribs posteriorly here, clavicles, humeri, scapula, a little bit of the jaw. This is a female patient, so they have some breast tissue, and you may see that in some of your pediatric patients, depending on when they start going through puberty. And this is just a more demarcated chest x-ray that shows a few other things as well, such as like where the superior vena cava might be on the right side of the chest. But if you want to see more, there's a QR code and a link to where I got that picture. All right, so then we'll scoot on to the lateral view. And so again, this is the same patient, so they have some breast tissue that's present. But so one of the places I like to start is the spine. And so the shoulders in the upper part of the spine tend to cause the spine to be more dense. And as you come lower, the soft tissues move out of the way, and you really only have lung that the x-ray beam is trying to penetrate. So as you come down the spine to get more loosened. I'll also draw your attention to the cardiac silhouette here. So the right ventricle is more anterior, the left ventricle is more posterior, and the atria are kind of superimposed on each other. This is where the pulmonary vessels all kind of are together. This is the trachea here. But there's this anterior clear space in front of the heart that should be present. It may not be present sometimes in our younger babies for a reason we'll get into in a little bit, but in our older kids, we should have an anterior clear space as well. And then I'll kind of look at the diaphragms, make sure that they look nice. Here's our costophrenic angles posteriorly, and then just check the other soft tissues. Like here's your sternum in this plane, and then the spine, just to make sure it is intact. So here's again, another marked up lateral chest x-ray that shows you some of the other anatomic structures that are present, including the stomach bubble. And again, another QR code if you want to see the YouTube video that this was taken from. So this is a patient who is a younger child. And so looking at the lateral view, how we're talking about the anterior clear space, we see that that isn't there, that there's some opacity that's there in that anterior clear space. And looking at the frontal view, you may see this kind of triangular opacity that's there along the right heart. And this is the normal thymus. And so one thing to look for it being a thymus versus like a pneumonia or another sort of consolidation is the thymus tends to be denser centrally. And then as you come out toward the edge, it has a sharp edge with the lung, and it begins to do sort of a fade toward the end where it's a little bit thinner. But this look is called the thymic sail sign. And so it's when you have this very sharp triangular border of the normal thymus. This is another example of a thymus in a baby. And so you may think it's a little bit harder to see, but if you look at the contours of the mediastinum here, this side's very smooth, and this side's a little bit more undulating than we're expecting, but this is what's called the thymic wave sign. And so the thymus, since it's so anterior, sometimes it can be modeled by the ribs instead, and it will cause this little undulation just as it kind of interdigitates with the ribs. So here is an older kid who has cough and fever. And so if we're doing our search pattern and we're coming across, we see that there's something over here that's denser than the other side, and potentially it's a little bit harder to see on the lateral. And so opacities by x-ray, here's just some tips that I've picked up on and learned from others about how to localize things. But really what we're looking for is structures being silhouetted. And what that means is you can't tell the borders apart from them anymore where you normally should. So in the upper lobes, you're looking for the superior mediastinum, or that anterior clear space may be opacified where it shouldn't be. In the right middle lobe or the lingula, the heart borders become obscured and the heart appears denser on the lateral radiograph. And then in the lower lobes, you don't see the diaphragm borders very well, and you see an opacity that is overlying the spine that we'll show you in a little bit. So opacities on x-ray are just anything in the lung that's other than air. So it can be water, it can be pus, it can be blood or cells. And they're really not specific by themselves. So we really need a good history or other radiographic signs that help us be more definitive in what these opacities are. So this is that same kid that had the the opacity that we noted. So here, if we look at our left heart border, we can really see the left heart border well. As we come down our right heart border, we really can't see it. It's pretty obscured. So this tells me that this consolidation is touching the right heart borders in the right middle lobe. And if we look on our lateral radiograph, we see that the heart has this kind of triangular density that's there, and it should be normally kind of more of this density, but that's where the right middle lobe opacities and the lingular opacities like to live on lateral radiograph. This is a younger kid who had a left lower lobe opacity, so this can be hard, especially if you only have the frontal, because you may not notice it anywhere since it's superimposed behind the heart. But if you look at this diaphragm board, you can see it very well. And as we come out here, we really don't see the diaphragm as clearly, and especially behind the heart, we don't see it as well. And then as we come down the spine, as it should be getting more lucent, but instead it stays fairly dense. And so this is what we call the spine sign. So this tells us that there's a lower lobe opacity. And so this is a left lower lobe opacity. This is a different kid who came in with kind of a chronic cough fever situation. And so here we have a right upper lobe opacity that's there, but it's not as confluent as our other pneumonias. It's a little bit patchier. It was a little bit atypical. And if you also look very closely, you can see there are these tiny little calcifications in the mediastinum and toward the right hilum. So these are calcified lymph nodes that you can see in primary tuberculosis. So in kids, when they get the primary infection, they tend to have more of a lobar pneumonia, but it's not quite as confluent as our typical bacterial pneumonias, and they'll get mediastinal and hilar calcifications, which are sometimes called gum complexes. In older people, when it's a TB reactivation, we look more in the lung apices for pulmonary opacities that manifest in that aspect. This is what bronchiolitis and reactive airways disease looks like. So here is a normal chest x-ray. And so there are some pulmonary vessels that normally are present on the frontal view, but they're usually pretty thin and they'll kind of gradually taper out. If we look at our kid who's got bronchiolitis, we see that it's a lot busier centrally. And so sometimes people will call this a thickened interstitium, where there's a lot more density that's in this interstitium bilaterally than there should be, more so than the vessels would account for. So this is what either reactive airways disease like asthma or what bronchiolitis can look like. This is a sickle cell kid who has some different opacities, and so they may present with fever or cough or chest pain or something like that. And so some of the things that we see with sickle cell children are that they can have cardiomegaly because of just recurrent sickling crises, and their bones may also show some signs that they've had osteonecrosis. So if we look at our left humeral head, the left humeral head is a little bit more sclerotic than it should be focally. So they've had a little bit of avascular necrosis in their left humeral head. And if we look at some of their vertebral bodies, this one has this nice square shape, which it said, but some of the other ones are kind of getting a little concave at their superior and inferior end plates. And so these are what are called H-shaped vertebral bodies that we'll see often in sickle cell disease as they get osteonecrosis of the end plates. And looking at our friend, he also has some opacities that are present in both lower lobes. So the right one, you can see a little bit of patchiness near the diaphragm, so it's a little bit silhouetted, but the left one's a little bit more confluent. We can't see that diaphragm well. And again, as we come down the spine, it gets more dense back here. So this is, again, showing you they have a lower lobe opacity. In this kid, it could be acute chest syndrome, but it could be pneumonia as well. This is a different child who had sudden onset drooling and dysphagia. And looking at the lungs, you may not see an opacity initially, but as you're kind of comparing the lungs back and forth, this one looks a little bit more expanded and lucent compared to this one. And so in younger children, especially foreign body aspiration or ingestion is a concern. So it's more likely to aspirate if they're under 3. And then if they're under 5, they're more likely to have an ingestion. The most commonly aspirated foreign bodies are food, which typically are not radiopaque. They can also ingest hardware and pieces of toys. And then more commonly in Tanzania, you can ingest coins, fish bones, which not all fish bones are radiopaque, just as a fun fact, some are, some aren't, hijab pins and plastic beads. So the first step in foreign body aspiration is if the patient's stable, you can go ahead and do an X-ray. And so you're looking for either a radiopaque foreign body that you can quickly identify or signs of a radiolucent foreign body. So things that we're looking for a radiolucent foreign body are a lung volume that doesn't change during the respiratory cycle, particularly in expiration. So if the chest X-ray is taken during inspiration and expiration, the affected lung won't collapse as appropriately as it should. In younger children who can't necessarily cooperate with inspiration and expiration, you can do decubitus positioning where you lay them on one side and then the other. And the lung should normally become smaller and more opacified if it's the dependent lung. And if it doesn't do that, then it shows you that there's some air trapping that's present. And so again, on expiration, the affected lung or in the decubitus positioning, the affected lung will be overinflated and hyperlucent compared to the other lung. You may also see some segmental or lobar collapse, depending on where the foreign body is. You may see some mediastinal shift as you start to get some kind of more air trapping. It may shift the mediastinum, and also radiodensity of greater than 1.1 suggests the need for bronchoscopy. So this is just an example of someone doing a radiodensity ratio. And so what they did was they took the Hounsfield units, which are the measurements of density in the right lung, and compared them to the left lung, and then they divided them. So you divide the bigger number by the smaller number. And if it's greater than 1.1, it suggests that there is some air trapping that's unilateral and they might need a bronchoscopy. So this was an example of someone who'd aspirated a non-radiopeg foreign body. So if we're looking back and forth between our lungs, we see that this left lung is more hyperlucent and overinflated compared to the left or compared to the right lung. This is another example of an aspirated foreign body. This was a peanut that was a little bit further down. That was toward the like the right middle lobe. And so we see that instead we have this opacity that's present that's giving some silhouetting of the right heart border. And then this is the case that we started with. So we saw that they had the more lucent left lung compared to the right. And here are decubitus images. And so when we look at the right lung, it's become smaller and more dense as it's being dependent in the right lateral decubitus image, which is normal. This is what we're expecting. In the left lateral decubitus image, this left lung does not collapse. It instead stays hyperinflated and lucent relative to what it was before. So that was abnormal. This kid had aspirated some popcorn. So this is another foreign body that was aspirated. So this is a screw, and you can see that it's causing some blockage, and then you're getting some atelectasis and air trapping. Well, not so much air trapping, more atelectasis throughout the left lung. And then this one looks like a connector of like an IV or something like that, but also was aspirated. And again, is causing some atelectasis in the right lower lobe instead. This is an ingested foreign body. And so, you know, this may be a little bit hard to see, so I blew it up, but so we see it's a uniform circle. So this is what a coin looks like. And so if it's just a uniform radiodense circle, it's most likely to be a coin, especially if it's flatter on one view. Here's a coin in the esophagus. So again, very uniform radiodense circle. And then when we do our lateral view, we can see here's the airway and here's the coin that's present. Some people may have been taught that you can tell the orientation of a foreign body in the chest depending on if it's like more facing you in the frontal view versus if it's kind of in the sagittal plane, but that apparently has been disproven. So you can't actually tell the location of it based on its orientation on the frontal radiograph. It's better to just do the frontal and lateral and see if it's actually in the airway or not. This is an abdominal radiograph. And so this person's also ingested a foreign body. And so here we see these two radiodense circles that are closely abutting each other. These are rare earth magnets. And these are actually a little bit more of a concern to us because the magnets can potentially get separated and then attract each other over different bowel loops and cause bowel perforations. So this is an important one to be able to recognize in case they've ingested magnets, because that should be followed a little bit more closely to make sure they don't develop a bowel perforation or a bowel obstruction. This dovetails kind of into our normal abdominal x-ray. So now we're going to switch to kind of abdominal pathologies instead. So when looking at an abdominal x-ray, again, just kind of developing your own system is important. So I'll usually start with the bowel gas pattern. And so when we're looking at the bowel gas pattern, we're trying to see if there's any particularly dilated bowel loops or that there's an area in the abdomen that doesn't have a whole lot of bowel gas. In this abdomen, there's really gas throughout the bowel. And we can see that it's not dilated. Our internal control for being dilated, if you do the interpedicular distance in one of the lumbar vertebral bodies, the bowel loop shouldn't be more distended than that. Some of the exceptions are if you have an older kid who's got a more developed colon, it may be pretty close to that, but still shouldn't be too dilated. So after the bowel gas pattern, I'll go ahead and look at the bones just to make sure that the bones look normal. I'll check my lung bases, make sure they look good and there's nothing in the upper chest. And then I'll kind of go through my and look for any calcifications, which in this case, we don't see any abnormal calcifications, but I'll do the organ shadows. And so we can see the kidney shadows that are up here bilaterally. We can also see the stomach bubble, which is kind of an organ shadow in a way. This pink one is the liver shadow. And then these blue triangles are the psoas shadows, which you can actually see if in a pretty well done radiograph. And then the last organ shadow we can see is the splenic shadow. So we get kind of an idea of the organs, even though we can't see them very well, as Dr. Masuma said, for how X-ray can't really differentiate soft tissues very well. So this is a 4-year-old with abdominal distension. And so we were talking about how the bowel loops shouldn't be more than the interpedicular distance of the lumbar vertebral body. And we can see that these very much are. And so these are a lot of dilated small bowel loops. We don't really see any gas in the colon or really in this left lower abdomen. And then on our left lateral decubitus image, which is so kind of the right side is the side that's anti-dependent. And so air will rise to the top. We see a lot of air fluid levels. And so this is really what an obstructive small bowel gas or small bowel obstruction would look like. And in kids, there are kind of a differential for bowel obstructions. And so we use the mnemonic that's called AIM. So each letter is duplicated, but it's adhesions and appendicitis, intussusception, inguinal hernia or other hernias like an internal hernia, malrotation with midgut volvulus, and miscellaneous, like and Meckel's sometimes people will have it. I highlight the malrotation with midgut volvulus in orange because this is considered a surgical emergency. So it's less likely in older children, but it's an important one to kind of keep in the back of your mind. For kids who are younger than 3 months of age, the haustra haven't developed in the colon. And so it's a little bit harder to tell what's colon versus what's small bowel. So instead we do proximal or distal obstruction, and we refer to it as proximal to the ligament of Treitz or distal to the ligament of Treitz. And so for babies with a proximal bowel obstruction, meaning before the ligament of Treitz, it's really pretty much anything that's affecting the duodenum or the stomach. And so you could have a duodenal atresia or REB. You could have an annular pancreas. Again, the malrotation with midgut volvulus is a surgical emergency. This time I have it in red because it's much more likely to present in this age group rather than our older kids. You could also have a jejunal atresia, and you could have hypertrophic pyloric stenosis as well. So this is an example of a distal bowel obstruction in a baby. And so when we're thinking about proximal or distal, again, with it being proximal or distal ligament of Treitz, we see there's a whole lot of bowel gas that's dilated in this baby. And so it's definitely distal to the ligament of Treitz. And so for babies, the differential for distal bowel obstruction is having ileal, colonic, or anal atresia, having meconium ileus, or having Hirschsprung's disease for congenital reasons, and then acquired reasons or necrotizing enterocolitis. Again, having a volvulus or having an inguinal hernia. So these were 2 kids who each had malrotation with midgut volvulus. So this child didn't have any past medical history. He just had bilious emesis. And we can see that there are some bowel loops that are getting a little bit too dilated now in the upper abdomen. If we look at the interpedicular distance, those bowel loops are a little bit too wide. That being said, this is another baby. He had a previous diaphragmatic hernia that got repaired, and this bowel gas pattern looks very normal. So having a normal bowel gas pattern does not rule out malrotation with midgut volvulus, unfortunately. So you do have to kind of prove it another way. Typically we'll do fluoroscopy, which is like doing live x-rays. So radiology performs it and they watch contrast be either swallowed, or they'll sometimes put in an enteric tube or an NG tube, and they'll put contrast in that way, and they'll see how the contrast moves in the stomach. And this is a normal, what we call an upper GI series, or a normal upper GI, which is a fluoroscopy study. And so the contrast is dark. And so here's the contrast in the stomach fundus is the stomach body. This is the pylorus. Then this is the first portion, the second portion, the third portion, and the fourth portion of the duodenum. And this is becoming the jejunum. And so our duodenojejunal junction should be to the left of the spine. So here's your spine, and it's to the left of the spine. It should be at the level of the pylorus or higher. So this is at the level of the pylorus. This is a normal bowel rotation. And if we see this, we go, they don't have malrotation, and they don't have malrotation with midgut volvulus for sure. This is an example of one of the babies that had the midgut volvulus, what it looks like by fluoroscopy. So in this case, we gave them the contrast, and we see instead of it crossing over to the left of the spine to the level pylorus like it should, it instead makes this corkscrew shape, which is what the volvulus really looks like when contrast can get through it. This contrast did manage to pass through that volvulus and then kind of come up to the left upper quadrant, but when they took him to surgery, they did still have a malrotation with volvulus. This is what malrotation without volvulus looks like. And so here you can see that they have some contrast in their duodenum. And as I play this little clip, we can see that instead of going to the left of the spine, the contrast wanders over to the right side of the spine, but doesn't make that corkscrew shape, and nothing is particularly dilated. So this was just an outpatient who happened to have intermittent vomiting and was found to have malrotation without volvulus at that time. All right, so we're moving on a little bit to a different pediatric emergency. So this is a 2-year-old with abdominal pain. And if we're looking at the bowel gas pattern, nothing is particularly dilated. It does seem like there's a little bit of paucity of bowel gas in this right upper quadrant. And then on our left lateral cuboid image, we see that there's kind of this soft tissue density that's present in this right upper quadrant that looks like it's within bowel, what we call an air meniscus sign, where it looks like there's a crescent of soft tissue that's surrounded by air. And so in this age group, we're really worried about intussusception. And he got an right upper, or he got an abdominal ultrasound, and we found an intussusception. And so here we are in the right upper quadrant. This outside layer of bowel is called the intussuscipiens. I think of it like recipient, so it's kind of receiving the other part of the bowel. And then the inside part is called the intussusceptum, which is the part of the bowel that's kind of telescoping into the other part. Typically, when we refer to intussusception, we think of ileocolic intussusceptions. So ones that go from the ileum that go into the colon, and they tend to be a little bit larger. So this one was about 3.2 centimeters, which is a good size for an ileocolic intussusception. This image is our color Doppler image. And so what we're doing is this is an image that shows us blood flow within the intussusception. And this intussusception has good blood flow. That's more reassuring for us because it means that bowel loop is not getting ischemic. And so there are a few other radiologic signs that we'll look for, like free air, to make sure that we can treat these in our department. But we can perform an air enema to do treatment for these. And so if we're looking at our air enema, what we do is we take a rectal tube and we put it into the bottom, and then we take it's effectively a sphygmomanometer, the little blood pressure like pumper thing, and we inflate air, and we watch under fluoroscopy to see how the intussusception reduces. And so here we have air throughout the colon, but then we've encountered this soft tissue density here. This is where the intussusception was. And as we start to insufflate air, we keep moving that soft tissue density a little bit more proximally. So now it's more toward the base or the cecum. And then in our third image, we no longer see that soft tissue density. Instead, we see a lot of small bowel gas, which tells us that we were successful in reducing the intussusception. This is another kid with an abdominal x-ray. And so bowel loops don't look particularly dilated. Some of them look a little bit atypical in that they look kind of amorphous, which is a little unusual. And then when we look very closely, we can see that there is an abnormal calcification overlying the right sacrum. It would be hard to tell by radiograph. This could be potentially a kidney stone or ureteral stone at this point, but it would be awfully large. It could also be an appendiculith or some other calcification. So here's a normal appendix by ultrasound. And so here's the appendix here, and this is it kind of in the axial dimension. And so when we look at the appendix, it has a normal gut layer. So it has this kind of more echogenic wall, and then intraluminally it's a little bit darker, but the wall is very well defined. This is some musculature that's adjacent to it. So some of the abdominal wall musculature that's present. And there's a little bit of mesenteric fat around it, but it's kind of a gray that's maybe just a little bit lighter than the adjacent muscle, but not very bright. This is a different kid who had appendicitis, but also had an appendiculith. And so here we see that the appendix is pretty dilated compared to what it should be. We see the appendiculith that's present, and the fat around it is considerably brighter than the adjacent abdominal musculature. So that tells us there's fat straining around the appendix, and they do in fact have appendicitis. This was just our baby who had the distal bowel obstruction to show you what he had. So we went ahead and did a contrast enema for this baby, which is, again, a fluoroscopic study, but we put in contrast now through the bottom and see how it travels through. And we see that the rectum here is much smaller than the sigmoid colon. And then everything upstream of that rectum is very dilated compared to the rectum. And this is diagnostic of having Hirschsprung's disease, which is the most common cause of neonatal colonic obstruction that's congenital. It's caused by ganglionisis of the affected segment of colon. And so that affected segment spasms, and then everything upstream to it dilates because stool doesn't pass well through that segment. And usually they present with failure to pass meconium the first few days, but sometimes they can have a delayed presentation. If it's like a very short segment of aganglionosis, it may not be diagnosed till they're older. This was a 4-week-old baby with vomiting after every feed. And so as we're kind of looking at the different bowel gas pattern, the distal bowel gas, so distal of the stomach and distal ligament trites, there is some, and it's not very dilated. The stomach is very dilated. So this is a pretty big stomach. Sometimes you can get a big stomach when they're crying, but in the absence of them crying a whole lot, this is awfully suspicious that there's something going on, at the stomach, or like some sort of gastric outlet obstruction that's happening. And so we did a pyloric ultrasound for this baby. And so here's the normal pylorus, where we can see here's the wall that's present. It's a pretty thin wall, and they have some, kind of heterogeneous material that's passing through nicely through their pylorus. Here's the thickened pylorus. So this muscle layer is much thicker. It's about 4 millimeters instead. And then there's nothing that's able to pass through this channel. So you get kind of heaped up mucosa that's internal, and nothing will pass through. the rule we tell our residents is the wall shouldn't be thicker than 3 millimeters and the length should be more than 14 millimeters. So we call it the rule of pi because it's 3 and then 1, 4. So the first three digits of pi. The reason we pay attention to the length is sometimes you can have pylorospasm. So the muscle may be thick, but if the pyloric channel is very short, it's more suggestive of having pylorospasm. So in that instance, we'll just re-image them in maybe 15 minutes or 30 minutes and see if that goes away. And it often does. So in this case, the pyloric channel was also very long, which is more in keeping with hypertrophic pyloric stenosis. All right, so now we're going to talk about some common support devices. This is a module that I found very helpful as you learn them. I'm really hoping it actually is accessible in Tanzania. I had a lot of trouble verifying if it was, but if you just search Cleveland Clinic Pediatric Radiology modules, it comes right up. But tried to give you a link and a QR code as well. But you just make a free account and they have a whole lot of modules for a lot of things in pediatric radiology, but their lines and catheters ones is particularly wonderful. So it's a good one. So here's some common support devices. So endotracheal tube. It should be within the trachea and it should be somewhere between like the thoracic inlet to the carina. So usually say like about C7 to somewhere about T2. And so these are two lines that just show you about that window that it can be. This trachea or endotracheal tube ends at about the mid trachea, which is appropriate. These are enteric tubes. So depending on how they want to feed them, they can kind of have two different locations. So one is in the stomach. So this enteric tube is in the stomach. So if the baby's going to, or child is going to be gastrically fed, that's appropriate. Some may not be able to tolerate that and needs to be post-pyloric or in the small bowel. So this is a different enteric tube where it goes through the stomach. And then actually this is about where the pylorus is. And so its tip is in the proximal jejunum or distal duodenum. But this is a post-pyloric feeding tube instead. Sometimes they may get malpositioned. So instead of going into the esophagus for enteric tubes, they may end up in the trachea. And so this one has the tip that's overlying the right lung. And so this is taking an abnormal course for the feeding tube. And instead they've gotten it into the trachea and lower right lower lobe bronchi instead. So that needs to be pulled back and repositioned before they feed them. Other common support devices kind of along the enteric tube line. So gastrostomy tube is that they need chronic, they can't take anything by mouth chronically, but they can still tolerate gastric feeds. This is the gastrostomy tube. So it's usually pretty short and has a little small balloon that may be visible, but typically it's just overlying the stomach. If they need post-pyloric feeds chronically, then they can get a gastrojejunostomy tube. And so you'll see a hub and it has usually it's a much longer tube, but it still follows the course of the stomach and the duodenum. As we can kind of see, I tried to make a little line, but the tip should be somewhere in the proximal jejunum. And so this is an appropriate course of it. Sometimes the gastrojejunostomy tubes can back up into the stomach, which would not be good. Some common support devices you would see more in the NICU rather than in the ER setting. You can have umbilical arterial catheters or umbilical venous catheters. And so the umbilical arterial catheters, or the UAC, it travels from the umbilical artery to the ipsilateral iliac artery and then to the aorta. We like the tip between T5 and T9 because that avoids potentially getting into some of the vessels of the abdominal aorta or the great vessels, and you don't want it to be in there in case it can cause a thrombus in some of those vessels. So you want it kind of in between where nothing's really taking off. The umbilical venous catheter goes from the umbilical vein to the ductus venosus in the liver, and then its tip should be at the inferior cavulational junction in like the suprahepatic IVC. So this is a baby with appropriately positioned UAC in yellow and UVC in green. And so when we look at our UVC, it usually makes this nice smooth line to, this is about where the umbilicus is. And so it's entering that umbilical artery, going through the liver and the ductus venosus, and then ending up kind of at that superior or inferior cavulational junction. Our umbilical arterial line, usually the tip is to the left of the spine if they're normally, rotating, they don't have heterotaxy. But another clue that it's the umbilical arterial line is when this part's external, but when it becomes internal, it usually takes a little course down and then will come back up, sometimes make a little V shape. Because it has to kind of come down to get into that ipsilateral iliac artery and then come back up. But here's its tip in appropriate position. Other support devices that are vascular, so PIC, which is a peripherally inserted central catheter, or CVL is a central venous line. So they should follow the course of a venous structure, whether above or below the diaphragm, and the catheter should follow the expected course of the vein. So here's a right internal jugular approach CVL. So it's kind of following the right internal jugular vein, going through brachiocephalic and SVC, and its tips at the superior cavulational junction. This is a femoral CVL. So Sometimes they're short, sometimes they're long. This one ended up being a little bit shorter, but it's tips overlying where we expect the right common iliac vein to be. Chest tubes, we just want to make sure they're really within the thoracic cage. So you can have a straight chest tube like this one, or you can have a pigtail chest tube like this one. If you see on this kind of straight one, there's a little gap here, which tells you where the last side hole is. That should be within the thorax. The pigtail chest tubes, as long as the whole coil is within the chest, you're pretty good. VP shunt catheters, so they connect the ventricles in the brain to the peritoneum. And so the catheter should be continuous from the skull to through the abdomen with tip in the abdomen. And so here we see the ventricular tip. This is the intracranial portion. This is kind of the shunt reservoir and the programming valve where they can change the settings. But all this piece is continuous. And so we usually get two views to make sure it's continuous on both. We can see this whole piece is continuous as we come onto the neck. Again, continuous the whole way, appropriately positioned on the lateral radiograph. And then here it is with the tip in the right lower quadrant. And when we look on our lateral radiograph, the intra-abdominal portion should be actually in the abdomen. So here's the abdominal wall. You want to make sure it's within the abdomen, but this is all very appropriate. This was a kid who'd had their shunt catheter fractured. And if we look very closely, there's a gap here that they had to fix. So that was not a functional catheter. This one I don't know if they have these in Tanzania, but they have them here and they annoy me endlessly. But so this is not a shunt dysfunction. So here's the intraventricular portion, and then you see this gap that's right at the skull portion, and then it kind of continues out. So some makers will have a radiolucent gap in the intracranial portion. I think they make it of a different material. It's a little bit more flexible, that spot, but it's not truly disconnected. It happens to be radiolucent, but I personally hate this. All right, we're going to move on to MSK pathologies. So we'll talk about kind of normal MSK stuff using an elbow as our example. So one thing to look for pediatric radiology is you want to make sure the cortices are very smooth. So like as we follow this cortex, it's nice and smooth. We don't see any jump offs and on the same side. So all the cortex should be smooth and all the bones. We also, in the elbow, we're looking more for the ossification centers, which are labeled here. So here's capitellum, radial head. This is the trochlea. This is the lateral epicondyle and the medial epicondyle, and the olecranon's kind of superimposed back here. And then if we go on to our other view, this is our lateral view. And so what we're looking for too is is everything aligned? So does your radiocapitellar joint, that stays aligned. You know, your ulnotrochlea joint also stays aligned. This is your olecranon ossification center. And we also look for a joint effusion. So what we look for is kind of a radiolucent triangle or a dark triangle that's present anteriorly and posterior to the humerus. If you look very closely, and depending on what monitor you're looking at, if you have like a big computer monitor, you can kind of see this little radiolucent or kind of like darker part anterior to the humerus. That's the anterior fat pad. That can be normal to see. In a normal, well-positioned lateral radiograph, you should never see the posterior fat pad, and we don't see this here. So this is a normal lateral radiograph. So the pediatric elbow, a thing that we can think of is the ossification center. So the elbow tends to ossify in a particular pattern that's called crito. The main ones to pay attention to are the internal or medial epicondyle and the trochlea, because if the ossification order is off, typically if the trochlea is visible before the medial epicondyle, the medial epicondyle is there. It's just wandered off somewhere into the joint space potentially. You have to go find it. So here is a kid who has a femur x-ray. Their history was not moving leg well. And if we zoom up on the distal femur, we see there's a fracture here. And so this is kind of through the corner of the metaphysis. There's another one kind of on this side. And this is a fracture that's actually very concerning because it's a high specificity fracture for child abuse. So here are some of the other examples of high specificity fractures for child abuse, and they occur by this. The reason they're high specificity is they occur by how this picture is showing, where someone picks up particularly a child under 1 because they're still light enough to be picked up, and they shake them. So if the person who's kind of shaking that baby, if their fingers are like not quite posterior, anterior on either side, they can get rib fractures, especially with the squeezing force. If their thumbs are at midline, they can get sternal fractures. If their posterior fingers are at midline, they can get scapular fractures. Or sorry, if their posterior fingers are at midline, they get spinous process fractures. And if their posterior fingers are particularly off midline, like very far lateral, they can get scapular fractures. And the classic metaphyseal lesions are kind of the encompassing term for the metaphyseal corner fractures or bucket handle fractures. But those occur because the baby can't control their limbs very well. And as they're being shaken, they kind of get that twisting motion that occurs with their limbs, and they get those fractures. This was another baby who, as we're looking at images, we kind of are always a little bit vigilant for child abuse. So this was a kid who just wasn't tolerating PO very well. And they actually have healing rib fractures, which was, again, high specificity for child abuse. So they got worked up, and that was a surprise for our ordering team. This is a different kid, older kid. So they fell on outstretched hand. And so as we were talking about our, having our nice smooth cortex, if we look at our ulna, this cortex is nice and smooth. If we look at our radius, it kind of makes this little dip here where it makes a little buckle. And then if we look on our lateral in particular, that you see this little sharp contour deformity along the posterior radius. So this is what's called a buckle fracture. They're very common in kids. This is another example of a buckle fracture. This one's a little bit more pronounced. So here we see the buckling of kind of the proximal first phalanx near of the thumb. And when we're looking at our more global view of the hand, you can see the thumb's a lot more swollen than the other fingers. And so we'll also use some secondary clues like soft tissue swelling to clues into where a fracture might be. Kids have a special fracture classification called the Salter-Harris fractures. So you can apply this anytime a fracture touches the physis or the growth plate. They're numbered from 1 through 5, and they're in order of how disruptive it is to the growth plate to cause premature closure. So type 1 is a fracture that's just through the physis. Type 2 is a fracture that's involving the metaphysis, or it's above the physis. Type 3 is a fracture that's involving the epiphysis and the physis, or below the physis. Type 4 is a through fracture, so it's involving the metaphysis, the epiphysis, and the physis. And then type 5, they call it an erasure or crush, to like show you that the physis just gets pretty much crushed and there's no other fracture line. The most common fracture that's a Salter-Harris fracture is type 2, so that's usually a safe one to pick. This is a Salter-Harris 2 that was of the thumb as well. And so here we see this fracture line through the metaphysis. And then looking at the physis, particularly on this view, you can see it's widened here and more of a normal caliber here. So this fracture involved the physis. So this was a kid who had elbow pain after fall. So kind of testing the short-term recall of how we're looking. So here's our capitellum. It's normally aligned with our radius. The radial head hasn't ossified yet. But when we're looking for joint effusion, we see here's the anterior fat pad. That's called also the Sale sign. There's a lot of Sale signs in radiology, but we also see a posterior fat pad, which is abnormal. So when we look especially closely, we can see that there's a little fracture line through here and through this proximal humerus. This is called a supracondylar fracture, and it's the most common elbow fracture in children. Here's a different kid who also had a fall. And so we see here's this joint effusion again. So we see here's that anterior fat pad and that posterior fat pad that are abnormal. Looking at the humerus, it looks pretty good. But if we look very closely at our olecranon, we see that there's a little fracture line here that goes intra-articular. This is a medial epicondyle avulsion fracture. So again, if we're doing our search pattern, we see a joint effusion that's present. So anterior and posterior fat pads are visible. Nothing looks dislocated, and you may not see a fracture line necessarily. You see a lot of soft tissue swelling, particularly immediately. But if we do our internal, if we do our search pattern, we see here's capitellum, here's radius. We don't find the internal or the medial epicondyle, but we do find our trochlea. So when we go looking for it, there it is in the joint space. So this is abnormal. This should not be there. They'd have to get it out. This is a normal lateral C-spine X-ray. And so what we're looking for on our C-spine X-rays is here's the anterior vertebral line. So that should be all one continuous line, which is normally the posterior vertebral body line, which is also, again, kind of one long arc. It should be learned. This is our spinal lamellar line. So again, nice arc, very continuous. And this is our posterior spinal line. So all these spinal processes should make also a nice arc. Sometimes if the spinous process is a little bit shorter, it may not make that line as well, but as long as the other lines line up, then that's fine. We're also looking at our retropharyngeal soft tissues, and so, or prevertebral soft tissues, depending on kind of how you're viewing them. But when it's just the oropharynx, they're a little bit thinner in the upper cervical spine. And when the trachea and the esophagus divide, those soft tissues get a little bit thicker. So I think we say the rule is about like less than 5 millimeters up here for younger kids. And then the thing gets less than 8 in the lower cervical spine. So this was a kid who had neck pain after they jumped on a trampoline. And so if we do our alignment, we see that the C2 vertebral body anteriorly is a little bit offset from the underlying C3 and the rest of the vertebral bodies. And so is the posterior vertebral body line. That's a little bit more offset, but our spinal lamellar line is intact. And so this is what's called pseudosubluxation. We see this in kids under 8 because they have very large heads and more lax ligaments. And so what you'll end up seeing is the anterior and posterior vertebral body lines may be a little bit offset, but as long as the spinal lamellar line is intact, then you're fine. They're good, they're normal, it's just a normal variant. This was a companion case of a kid who also fell. In this case, when we do our lines, they do not line up on all three. So that was actually more of that was a real fracture. And you can see the fracture here. This was a kid who had an outside transfer. They'd had an unwitnessed fall in the bathroom. And so we see that there, again, looks like there's some pseudo subluxation at C2 on C3, but now the prevertebral soft tissues are very thick. And so the concern was, do they have a fracture or not? In this case, you can see the kid's head is flexed. So sometimes if they're not well positioned for a radiograph, you can get what's called pseudo thickening. And that's what this kid had. This was a repeat at our institution. And we see now their retropharyngeal or prevertebral soft tissues are very normal. And so this was just happened to be just kind of a technique related problem. This was another case of prevertebral thickening. This kid was a little bit different. They wouldn't turn their head to the right and have a fever. But so here we see the retropharyngeal soft tissues are very thick. They're the same thickness as lower down in the cervical spine. This persisted despite multiple lateral radiographs. And so they went on to get a CT to look for retropharyngeal abscess. And so here is the retropharyngeal abscess that's present in kind of the right neck soft tissues. So now we'll kind of quickly go over emergent neuroimaging. So pretty much for a lot of the neuroimaging, you really want to do a CT head without contrast because skull radiographs just tell you about the calvarium, and even that not particularly well, depending on how they're done. And the real question is usually what's happening to the underlying brain. So I would go ahead and just go with a CT head if there's a neuro issue. So this is what ischemia or infarction can look like, or stroke is what the kind of more colloquially called. So this is our normal brain on the right. And so we see that they're kind of three different densities. There's the fluid density, that's the ventricular system here, which is nice and midline. There's the white matter, which is kind of the next darkest layer. And then we have our gray matter, which is the lightest layer. And sometimes we have a little bit of CSF that you can see in the sulci. So here's a little bit of CSF here, here's a little bit of CSF here. But you should have three layers that are present in the brain. When you have ischemia or stroke or sometimes cerebral edema, you lose the distinction between the gray matter and the white matter. So you may see gray-white differentiation is lost. And so what we can see kind of in this right temporal lobe is that we can't really, it's not as like well defined as it should be, and as well as in this left temporal lobe and kind of into this left more occipital lobe, we see that we just can't really define that gray and white matter particularly well. So that's what ischemia and infarction can look like. This was a kid who had hydrocephalus. And so looking again at our nice normal comparison, we see here the ventricles have pretty sharp margins. They're pretty thin. Again, they're at midline. This little structure here is the temporal horn, and usually it's pretty small. You can see it, but it's very, very small. As you start to get hydrocephalus, the temporal horns are the first things to dilate by CT. So here are your dilated temporal horns. And then now we can see our lateral ventricles are a lot more blown out, like the edges just aren't as sharp. They're a lot more rounded and they're a lot more apparent. So that's what hydrocephalus looks like. Here are some examples of intracranial hemorrhage. So this kid fell and hit the front of their head. So here's their scalp hematoma. They have an intraparenchymal hemorrhage in their right frontal lobe. They also have a subdural hemorrhage that's present kind of along this right convexity with a little bit of pneumocephalus that's present. And you can see that there's a little bit of midline shift that's present. So here's your midline, and your ventricular system shifted a little bit over toward the left. So there is some mass effect from this hemorrhage. This is a different kid who had a trauma. And we can see that there's, again, kind of a subdural hemorrhage that's mixed density. So some areas are brighter, some areas are darker. This can be due to hyperbleeding or hyperacute bleeding if it hasn't had time to thrombose. If there's fluid, like CSF fluid that's in it, that's more simple. It can be a little bit more heterogeneous, or you can have acute on chronic bleeding that can also be mixed density. This is some subarachnoid hemorrhage. So this is within the sylvian fissure that's present with this little pink arrow. And then this is intraparenchymal hemorrhage that's more of a like kind of purpley arrow with a little bit of pneumocephalus that's present. And again, just to kind of show you the cerebral edema, like ischemia picture, the white or the yellow star shows you that in this left temporal and occipital lobe, we really can't see that gray-white matter distinction anymore, versus in our right occipital lobe, we can see the gray matter and the gray matter and the white matter very distinctly. This kid also has some midline shift to the right instead. Tumors can be tricky by head CT. We're often looking for kind of asymmetry or signs like secondary signs of things, especially if it's a low-grade tumor. So this was a glioma that was involving the left frontal and temporal lobe, and you can see that you can still kind of see some gray-white differentiation that's present, but we see that like this looks a lot bigger than on the contralateral side. It seems like there is some mass effect on the adjacent lateral ventricle that's present. This low-grade tumors may not enhance, so you may not get as much benefit out of using a contrasted CT versus a non-contrast CT. Typically, they'll go on to MRI and get a better look at them that way. This is a different tumor that was present. This was a brainstem tumor. They're a little bit easier when they're not the same density as the brain. So this was a more hypodense mass that was involving the pons, extending a little bit into the right cerebellum. And this was a diffuse intrinsic pontine glioma. So this was just a brief summary of what we did. So we did normal anatomy, support devices, specifically CSF malfunction. We talked about a little bit about child abuse, MSK injuries, and intussusception, proximal and distal bowel obstructions, hypertrophic pelvic stenosis, pseudosubluxation, and pseudothickening, foreign body ingestion, chest tray pathologies, or chest X-ray pathologies, and emergent neuro findings. So thank you all for going through the whirlwind. And are there any questions?
Thank you very much, Dr. Susan and Dr. Masuma, for a very wonderful and detailed presentation, which I'll say the presentation cuts across all healthcare providers that work within the emergency department at each level. And I'm sure we have all gotten a lot of knowledge out of the presentation. So I'll give only like 2 minutes. If there's any question that is burning that someone has to ask, you can just write it in the chat. Meanwhile, the next presentation is going to be in May 14th. So I'll just like to say all that have joined, get ready for the next presentation. That's going to be on May 14th. And it's going to be on pediatric ultrasound utilization in emergency setting. There's also going to be another interesting topic that all healthcare workers working at emergency department is good to know, because that's one of the point of care tests that we really use and we really need to know. So I'm just trying to see on the chat if there's any questions. Looks like we do not have any questions. So I'd like to say again, thank you for all the participants. Thank you, the presenters. We're all being on time, and I'd like to wish everyone a good evening and a good morning to Dr. Susan.
Thank you all so much.
Thank you very much.